Now, first of all, I must say, because due to the time zone difference, I can't have a live surgery. I hope we can, in the future, can apply surgery just like when we are doing a laparoscopic surgery. But before I begin, I may explain some of the operating system, because there are people who are very experienced and other people may just started to learn HIFU or may not have seen a HIFU system before. So I would like to just spend a little bit of time to present with some operating system and what we are looking at. And also, I must say I did speed up the video so that to save time. And for those who are very experienced in HIFU, please excuse me because I'm not as experienced as you are, but just give me good comment about this case, okay? Now, I'm starting to start off showing people the operating console, the interface we are using. And this is right side, you are controlling the transducer. This the right, the transducer will move to the right. This left, move to the left. This foot, the patient foot direction. H means the head direction. I hope people can see, but may be difficult by Zoom. A means the transducer go to the abdomen side. P means the back of the patient. And this the PZ and PZ plus. Now this is the ultrasound, diagnostic ultrasound in the center, where you control whether you can see clearly. Well, this is going to divide the fibroid or the uterus into many layers so that you can ablate or burn the layer, one layer by another layer. Now, the treatment is like that. You can see the patient lie on the machine. There's the uterus. And the transducer is going to send the focused ultrasound onto the lesion you are going to see. So you burn one by one, point by point, and then when you don't think enough at the anterior, you burn the anterior as well. Usually you burn more at the back because once you burn the one anterior, it may prevent more ultrasound to go to the back. So this is one of the principles we should use. We should burn the caudal side, the foot side, and then to the head, because in this way, the patient will have less pain because the sacrum is here and the lower spine is here. Sometimes the radiation heat can burn the, not burn, but causing pain on the patient. Now, so this actually how it operates. During the wheel time, you can see the ultrasound, we are moving the posterior, the transducer up. We can see the uterus over here. Now, we are going to find the fibroid, and there's in the middle. Now, usually the ultrasound is not, this ultrasound is not as good as what we are using in our clinic. We are using our ultrasound with very high resolution, but this one, after a while, you can see where's the fibroid. Now, we are dividing the fibroid into many layers. So each layer is around 5 millimeters. Depends on the size of the fibroid or adenomyosis, you can divide it into smaller layer. So usually we set at 5 millimeters each layer. We burn the middle layer where you have the largest area to burn and save. And then after you burn one layer, you move on to either the right or the left and burn another layer and burn another layer until you finish. Now that's important. Later on when you see my video, you know what exactly I'm doing. What we are doing is not just one plane, but because it's three-dimensional. So by moving the transducer, you burn one layer after the other layer, either right or left. Now, however, the so-called focused ultrasound, they have a fixed focal length. Therefore, for some patient, some very obese patient, we need to make sure that the focal length can burn the lesion we want to burn, especially those posterior large fibroids. But some patients are very thin, the anterior fibroid, you might need to put a water bag so that you elevate the patient so that your focus point from the transducer will be able to focus at the fibroid. The way the nurse to learn how to use the water bag is very important because it saves you a lot of problems. Now, how do we know we have ablated the fibroid or the lesion adenomyosis we want to ablate? Now, it's the thermal necrosis of the tissue and will change the ultrasound reflection. So this is what we call grayscale change. And the more severe necrosis, you may have the white patches. I call it white patches. There's many names for it. And you can see that we have burned this. So later on in the video, when you see this, you know that I've already burned the fibroid. Now, how do we know other than these white patches? Sometimes it doesn't appear because we can only see some grayscale change. We use microbubble to be able to visualize how much, whether there's any still perfusion within the fibroid. Microbubble is very small bubble. Compared to normal bubble we have seen, it's 5,000 times less than the normal bubble. So it's phospholipid with gas inside. They travel along the capillary so that any fibroid with blood vessel capillary inside, it will be sewn up by the microbubble. Just as this one, you can see this is a fibroid, big fibroid with endometrium here. And you can see the microbubble injected. And because the gas can serve as the ultrasound contrast, so that's why we can see the fibroid. Over here, we are turning from one side, the middle, to one side, and then go back to the other side, trying to assess how large the fibroid is. So you can see all this microbubble in the picture. Now, and then after we have done our surgery, the HIFU surgery, we then also inject microbubble. And at the end of the operation, you can see here, there's no more microbubble. Microbubble usually the sounding you can see, and the endometrium they're still intact. I can see the microbubble still there, but in the center you won't see any microbubble. So you turn from the center to one end and then back to the other end, trying to assess how big the area you have ablated. And of course, center may use MRI after the surgery the next day, but MRI in Hong Kong are expensive, so we are using this method. One of the most important issue is the focus point we need to focus the area we burn, but make sure this acoustic pathway is without any bowel. And it's important the bowel has gas. The gas, any gas, have the ultrasound wave, and then they will heat up. And the more prolonged it is, they may burn the bowel. So we make sure it is outside this triangle. So we are burning here, could be 90 degrees. Anything over here can still be 40, 50, we don't know. So we don't want the bowel to be in between. So we always try to, some way, either distend the bladder, this is the Foley catheter, push the bowel away, or put a water bag over here to push it away. You will later on see what I'm doing in the video. Now, so the patient I'm going to present today is a 47-year-old lady with menorrhagia and severe anemia. She has a submucosal fibroid of around 4 to 5 centimeters. She requests HIFU ablation after learning the HIFU ablation. And the MRI show is submucous fibroid, as shown in the video later. Now, the preoperative blood tests are done and localization tests. That means testing whether the fibroid can be visualized, the patient any problem. This a test done before the actual operating procedures. We don't want to a patient who cannot have this surgery occupying the theater time, so that we have done everyone localization tests to test is whether feasible to burn, to ablate the fibroid. So The HIFU ablation was carried out on the last day of last month, to record it for this section. Now you can see this is MRI showing the submucous and mucosal fibroid. And we usually see a field image, T2W, and this is a hypo intense fibroid over here. So after we assess the size, assess other things, whether there's any other fibroid, and we're starting to do the procedures. Now, that's how we prepare the HIFU ablation. There's, within the theater, you can see while we doctors are discussing about the case, how we go about it, and you'll notice that there's a large television here. I allow the patient some time to look at it and also explain to them what I'm doing, rather than we are doing it ourselves. You can see my setup here is my infrared monitoring is over here. Now, what the nurse is going to set up, we put a frame over her buttock so that we can put the infrared camera around here. So now you can see what the nurse are preparing. Now, so put a frame there, my infrared camera just over here. So we cover it so that the patient will not look like Mick. And because we need to let the buttock to elevate the heat if it's go through the buttock. Otherwise, the patient may complain of pain, or we cannot cover them with any coating. So when the patient is ready, we are ready, then we can start to do surgery. At first, I would like to do something like with a Zoom, hopefully with this type of platform, to be able to share my operation with other people. And however, I find that it's difficult. Now, this is the setup of the HIFU when we first started using a Zoom. Now, to start with, we increase the water level so that they can cover the patient lower abdomen, because in this way, it will cool down the temperature that may be there. Now, you see in the Zoom, when we take the video, it's not clear enough. So later on, I will show you more clear pictures from some of the recording I have from Chongqing. And however, you can still see what I am doing. I'm going to explain it. And we are moving because it's not going to be so clear. I'm using a faster speed. Now, we try to localize the fibroid, the uterus, and also to see the fibroid here. Now, I will explain to you what we are doing. And then in this way, we show the Doppler to outline the fibroid. Because the fibroid usually a pseudo capsule, you can see the Doppler surrounding it. So you know that it's the fibroid you are ablating, just like in here. So you can transfer the image by pressing this button. They will transfer to here. You can take a picture, just like previously. I got a frame here. Now I'm doing a microbubble. Now the microbubble, in this one, you can see there's microbubble in the uterus. Sorry that you may not see clearly. Also, I speed it up. You can see the fibroid, and I'm recording it. And so after I see the microbubble, I can identify the fibroid is here. This is the one, the focus point. I need to lower it to here. But when I lower it to the fibroid, I find that the gas going my way. So I need to put a balloon bed, water bed over here, so that to elevate the patient abdomen, so that I can have this focus point onto the fibroid. And then I need to divide the fibroid into various layers. That's how the so-called planning is doing. So this, I identify where is the fibroid, for example, from how many centimeter to how many centimeter. So I divided the fibroid into many layers. I started from the middle layer when I'm going to ablate. So I set the voltage to 400 volt. and then set it to hit it 1 second, relax for 3 seconds. And in this way, 5 repeat, that means burn 5 times. You can see the number of seconds you have ablated the tissue. Now, in fact, by pressing this button, it will turn red. Now, whenever the water content is too low, and there's various alarms to help you, you can see already there's white patches appear. Now, in order to see clearly, I show you the video I got from, this is the video I got from Chongqing, a better recorded video. Now, again, I show you the later parts of the video. Now, so this is where the bladder is here, and the fibroid is over here. Now, so I'm changing, starting at the center of the fibroid after the microbubble, and I set the voltage to 400. You can see I press here, it turned red, so it is ablating. So it ablates 1 second and rest for 3 seconds. So that's the amount of total second I burn. So it's also recorded over here, and how many seconds I burn. And you can see after 10 seconds, there's already white patches appearing. And there's sometimes without patches, you can see the grayscale change. When you first started, I must say that it's difficult to visualize the changes. Only when there's white patches, you're starting to say, hey, we are doing it. But now you're able to see the fibroid. You can see I have moved from 4 to the other level, 5 level now. This a technique I learned from Dr. Zhang. It seems that if I'm going to ablate the one whole area together, I need to move the machine, and that might have the bowl in between. So instead of moving to the front, I burn each of the layer at the posterior caudal bit first. Now I move from the 4th now to the layer 6. So when I see the ablation is more or less enough, I move to another layer. There's another layer, I'm moving. So when you move the other layer, there's not much white patches. And the more you ablate, the more you're able to see. Now, this is the one after ablation, but there's already too close to the edges of the fibroid. We are told we probably don't go to the edges of the fibroid because this one, remember, is submucosal fibroid. We don't want it to burn too much into the endometrium. So we are moving from 4 to another layer on the right side. This is the right side at the level 5. So all at the posterior. And so at the caudal end, we want the heat to spread to the south or to the abdomen direction and to the front. You can see weakly the fibroid. Now I move to another layer at the side. So after burning, you can see it's quite obvious, and the fibroid starting to have all this white patches or grayscale change. This is, if they are not white patches, sometimes you can see grayscale change, and you can see this the fibroid. Now, but I admit that this one, I am pitting it a bit too low. I need to burn, the fibroid is larger than this, so I need to move on. So what I did is try to identify the location, the size of the fibroid by the Doppler. So that's what I have just done. But you can see more or less the fibroid I can see is other than the posterior, is not enough. So that is the whole fibroid. And I use Operat to identify it as well to help me. And then the front, it still needs some ablation and the top a bit. So I try to relocate the water bed in this way to push the bowel away. So you can see the water bed is more moved to the caudal end. So I moved the pointer, the focus, to more to the caudal end, so that I burn deeper. In this way, I managed to ablate the whole fibroid. I would say could be 100%. But when you see, when we have already white patches in front, it's more difficult to see the changes at the back. But still, you are delivering some energy over there. So it still burns the fibroid. Later on, by microbubble, you can see the appearance of the non-perfusion volume. So I'm already moving, trying to burn. It seems that it doesn't move. And so a middle first and move to the side. So, and this is again, further on, I just give a few heat at the middle of the fibroid. Because every time we put the water bed, sometimes the uterus can be moved a little bit. So that's one of the problem. Sometimes we need to be able to see what we are ablating and how large is the fibroid. And now, when we think we are more or less finished, then what we are going to do is to inject microbubble inside again. So there's going to wait until one thing is you can see the fibroid and being burned. There's over here. Now there's the microbubble. Now one thing is we are using oxytocin. You can see there's no perfusion in the fibroid. So I'm turning it from one side to another. When I measure the size, it corresponds to the size of the size of the submucous fibroids in the MRI. So I usually compare here and the appearance, and so before and after. So, and I use again the Doppler to outline whether this is the real fibroid I'm treating. So that's how I finished this case of a 5 centimeter fibroid. So I managed to complete the procedures in 30 minutes for this submucous fibroid, and the patient recovered well 1 hour in the clinic. She was discharged home with analgesic, just some painkiller. She remained well and come back to follow up in 1 week's time. And her fibroids already show shrinking in size from 4.5 times 4 centimeter in the MRI in this pictures to 3.1 to 3 centimeter by ultrasound. So she did not have any side effect or complaint. She will be visited again in 1 month and in 6 months' time. And we believe that this size of the fibroid, if it's effective, it probably disappear within a year. So hopefully her menorrhagia and all that will be will be under control after 1 or 2 bleeding. Now, that's the whole for the presentation. And I choose a case, not a difficult one. Unlike our laparoscopic surgery, we usually show the skill we have for difficult one. But because of the time limitation and otherwise it can be very boring. But there's quite a lot of technique we need to learn. So especially for multiple fibroids or adenomyosis. So this is just a simple case for me to present. Thank you for your attention.
Okay, thank you, Professor Felix. Maybe one question from audience? Okay, one question for you, Prof. Felix. Is there any contraindication for the HIFU?
Yes, in some big fibroid, especially MRI, the T2 weight image, if it's hyper intense, that means they're quite vascular. Then it's very difficult to ablate. it may take too long a time. And we usually make sure that oxytocin can control. Now,
Okay.
of course, the other major indication is that any suspicious of is leiomyosarcoma or any lesion with possible malignant change. We need to be very careful. Now, some position of the fibroid are not easy to ablate, and some may be easy for laparoscopic surgery. For example, a pedunculated fibroid. Okay, so otherwise it will be, yes, we can ablate it. It takes a long time to become regress. The lump is still there. So now, in fact, we can ablate nearly up to 90% patients will come to us. So the rest depends on the level of the skill. So I myself set up the fibroid into various levels of skill, just like our laparoscopic surgery, so that hopefully our doctor will learn the skill from one level to another. But unfortunately, it's not that easy. We use just one section. One question is, how many sections are used for large fibroid? The machine from Chongqing is very effective. If you do well, we just use one section. We don't have to use the other section, even for 12 or to 14 centimeter fibroid. And of course, why people asking this question, especially the insurance company, because there are some other hyperthermal machine. They are not as effective as the machine we are using from Chongqing. That's why they may need several sections to avoid the skin burn and other not effectiveness. Then they need to use several sections to do it. Now, one question I can see is the HIFU in degenerative fibroid or degenerating fibroid. Yes, we have many fibroid. They are large. They also have area of degeneration. But degeneration may offer problem when you hit at it, but we are using the MRI to guide us as well. And we can know where the degeneration, but it still can be done. And the degenerative area already is not going to grow. So it doesn't really affect your result too much, but it may take a long time for it to regress. Okay, so yes, we can do it. And so the courses, provide any course for HIFU. Yes, APAGE and many of our center, we are trying to set up some training program together with Chongqing HIFU and some center in China. It's going to hopefully provide training course for people who learn HIFU, how to do it. And in fact, the International Society of Minimally Invasive and Virtual Surgery Society do have quite a lot of teaching on the web. People can go to the web to see many of the teaching from this society website. So, okay, any other question I may see? Yeah, I think more or less the question I've answered. Any other question?
I think it's
one question is what kind of complication or HIFU procedures often occur for beginner? Now, for beginner, you know the limitation, just like laparoscopic surgery. I think HIFU surgery should be trained not just by observing more, but to do it under supervision, under good supervision. So in this way, we'll minimize the complication. Besides this, I mean, there are fibroid that can be, or adenomyosis that are difficult to do. And for example, posterior fibroid, large fibroid, anything more than 8 centimeter, multiple fibroid. And so we should have various level of skill to learn and various level of fibroid. But unfortunately, we may not be able to divide so closely different type of fibroid. Okay, and I think that's all. I'm getting too late now, I believe.
Yeah. Thank you, Professor Felix Wong, for your nice presentation and discussion.